Tonight, we are in session 2 of our SMART Team series. This is the Spine and Musculoskeletal Actionable Resources and Tools program for the Transforming Episode Accountability Model. And we are really just delighted to have everyone joining us tonight. Our session title for tonight is Bone Health Optimization Implementation to Align with CMS Team Quality and Cost Metrics. For those of you who don't know me, I'm Rita Roy. I'm the CEO of the Spine Health Foundation. And just a few words about our organization, why are we here and what are we here to do? We say that too often spine health challenges steal life's simplest joys, not because treatments don't exist, but because the path to them is unclear. So we were built to ensure that all those suffering from spine conditions can reclaim the life they love. We provide trusted information, education, and advocacy driven by the belief that better understanding leads to better conversations, and better conversations lead to better patient outcomes. So, SHF serves a critical gap in spinal health by representing the voice for patients in connection with spine health professionals on our medical and scientific board, and along with premier spine health professional societies through the Coalition for Spine Health, and fueled in partnership with industry leaders through our Spine Health Leadership Council. We launched 5 years ago. We were built on a 15-year research history. The Spine Health Foundation is the only patient-centered nonprofit organization dedicated to helping patients overcome the full spectrum of debilitating spinal conditions to restore their lives via patient education, advocacy, and patient-reported outcomes research. And on the next slide, just a word about our medical and scientific board. We talk about our evidence-based, professional, trusted, authoritative content that we design and develop along with our board. And I'm really pleased to acknowledge Dr. Rajiv Sethi, who I believe is on the webinar tonight. Dr. Sethi is the chairman of our medical and scientific board and a member of our board of directors. And in the words of Raj, the SHF is an important venue for spine physicians to advocate for patients and make spine care more predictable and sustainable for generations to come. Thank you, Raj, for your leadership and your support of the organization. And a little bit about me. You can read more about my bio. I'm a general surgeon by training. I spent a career in medical education and communications. I've been the CEO at the Spine Health Foundation for the last 6 years. And next slide. So our work to drive spine and bone health optimization, a central component of the CMS team program is the need to coordinate patient care to improve the patient outcomes around 3 spine and orthopedic and bone health procedures. So preoperative osteoporosis diagnosis through measurement of bone density and bone quality, and treatment of osteoporosis, largely with anabolic therapies, is important to identify underlying osteoporosis prior to any surgery. We've developed a number of healthcare professional education programs, including a 4-part CME webinar series on spine and bone health optimization. These programs emphasize pre-surgical osteoporosis evaluation, covering topics including DEXA bone density tests, trabecular bone score, and CT Hounsfield units. We describe the use of osteoporosis anabolic therapies, and we identify the role of multidisciplinary care, patient education, and post-surgical monitoring in improving surgical outcomes and secondary fracture prevention. You can find all of this information at our CME website. It's free and open access. Thank you, David. Next slide. So for this webinar series, I've already sort of introduced it at the get-go here, but TEAM is the mandatory episode-based alternative payment model. Over 700 hospitals will be required to participate to coordinate care for people with traditional Medicare undergoing one of the surgical procedures in the model. 3 of the 5 episodes include spine and musculoskeletal, which includes spinal fusion, surgical hip and femur fracture treatment, and lower extremity joint replacements. So given the predominance of orthopedic and spine procedures in TEAM, this webinar series has been designed to help educate the orthopedic, spine, and bone health fields on the model, how best to implement it, and which will positively impact the work of the National Spine Health Foundation to drive our bone health optimization and osteoporosis screening, diagnosis, and treatment information. We'd like to thank the sponsors of this program who've helped make this series possible. Our sponsors this evening are MediMaps Group and Radius Health. And so just a quick overview. Am I over time? I'm 2 minutes over time for my welcome and introductions. We're going to turn the program over here to Dr. Dymar, who's going to go over the essential steps for establishing and enhancing a bone health optimization program. That will be followed by Dr. Bervin, who will speak about creating a streamlined experience, optimizing workflow, and perioperative protocols to make informed decisions. And then Dr. Brian Cunningham will present his bone health optimization teams and the clinician presentation. We will plan to leave some time at the end for Q&A. We invite people to just go ahead and enter their questions into the chat, and we'll read those out as they come in, and we'll try to end right on time at 9 o'clock. So without further ado, I'll introduce John Dymar just quickly here. The full bios will be available on our website. Dr. Dymar is our orthopedic surgeon and clinical professor from the University of Louisville School of Medicine, where he serves as the chief pediatric orthopedic surgeon at Norton Children's Hospital as well. He directs the resident basic science education and plays a pivotal role in training future orthopedic surgeons. Dr. Dymar specializes in the treatment of spine deformities, tumors, degenerative diseases, and trauma. Dr. Dymar focuses primarily on, particularly on cervical and degenerative spine conditions. His expertise and dedication significantly enhance both patient care and medical education. And you can read about his medical education again on the bio that will be included. Dr. Dymar practices at Norton Leatherman Healthcare Center in Louisville, and I'll turn it over to you now.
Well, I'm going to essential steps of setting up a bone health program. A lot of places haven't done this yet. I love bone health because I like to be a detective, and I've always liked research, and really I learn something every day. I was just at a tumor conference that I learned things about great cutting edge treatment of that in spine surgery, which is really changing. As you know, osteoporosis is endemic in the United States. They just tonight took their warning labels off estrogen, which is probably why we have a whole generation of women that have bad bone more than we used to, because estrogen does seem to slow down the loss of bone. So the population is aging, so we can expect this both in women and men. Men get it 20% of the time, or responsible for at least 20% of the population, so don't forget us. So we're talking a little bit about diagnosis. Osteoporosis is just a decrease in bone quantity and mass. It simply gets weaker. The binding of the bone together loses its attachments, and you can fracture just rolling over in bed. Osteomalacia we classically associate with people that abuse alcohol, and it's really decreased bone quality. The collagen matrix doesn't get put together well. Most people have actually a combination of this. So the trabeculae, as they get weaker and weaker, the end plates will collapse, specifically in the spine, with just rolling over in bed. 900 newtons, 800 newtons will do it. And so we'll get spontaneous compression fractures, or fragility fractures, as we like to call them. So life's all about making more bone production and less bone loss. And you don't identify the risks. It runs in families, white females, Northern European descent. We all know this. Genetics, steroids, oophorectomies, dietary deficiencies. You can adjust a lot of this and slow it down, but not improve it by stop smoking, exercise, vitamin D, and things along that line. And of course, we all should be taking calcium. I always put this on the right because these are the questions they ask us on our boards all the time. You know, lactating females is a very common one about how much more calcium you're going to have to take, and particularly also vitamin D. So really, you need good vitamin D, calcium, phosphorus, PTH, and calcitonin. They all have to be in absolutely perfect balance. You get vitamin D deficiency as children, you get rickets as adults, you get osteoporosis, and various other genetic causes of it. And the bottom line is that we see this all the time. And this poor lady here, her T-scores were actually minus 4.5. And whenever you see that, you ought to think about hyperparathyroidism and get a PTH. Now, you make the diagnosis via three pathways: a previous fragility fracture, a fall from height. If they break their hip or break their wrist, by diagnosis, you can treat them for osteoporosis, and do a fracture score, for example. The other thing is, and that's what we do, the DEXA scan is what's commonly used. It's DEXA or DXA. It has many other scans you can do out that we'll talk about briefly. And of course, what spine surgeons use the most, at least in my group, are optimistic HUs from the regional COA scan. So this is what a FRAX thing looks like. It'll calculate your 10-year probability. any fracture low energy is pathognomonic for osteoporosis. And you can download this off the website. It's one way you can diagnose osteoporosis. The other things, of course, are the DEXA scan, of which the trabecular bone scan is a program you can run on it that'll look inside the vertebrae, which is particularly useful in people with a lot of spondylosis. And of course, the CT scan, specifically the Hounsfield units, you have the quantitative. And of course, there are some MRI, the VBQ score, but they're not quite as mainstream as the other ones. This is the classic DEXA machine. It's a dual beam. It'll actually check your what your bone density is. It's very low radiation, and you can calculate the T score and the Z score. Z score is comparing it to your own age group, while a T score compares it to a normal, healthy 30-year-old adult retrospectively in a way. So DEXA scans are available most everywhere. Walgreens, the bowling alley, a lot of other places. They become fairly ubiquitous along with MRIs. So this is the classic reading you'll see when you have somebody with these fragility fractures I've showed you on the left. Basically, from -1 to -2.5 is osteoporosis, is osteopenia, and anything greater than -2.5 and greater, up to about 3.0 or 4 with a fragility fracture, is osteoporosis, and then severe osteoporosis is those results combined with a fragility fracture. So keep this in mind when you see this score. This is a typical one that you'll get from your radiologist here. You actually see regions, and you really want to pay attention to the trochanteric portion of the neck, because if this is -2.5, it trumps everything else. You've got osteoporosis, because this is one of the last places to go. And you may have it worse in your bone. And it can be very regional. You can have the wrist or the spine actually be quite different. And so you have to kind of add things together. No one test will give you the definitive answer about osteoporosis unless it's ridiculously high. So pay attention. This person happens to have particularly good bone. I put it as an illustration here, so you're rarely going to see anybody with this good a bone, quite honestly. So this is really what the T-scores denote as far as what you're going to. Normal is greater than -1.0, 1.0 to 2.5 is osteopenia, less than greater than 2.5 is osteoporosis, and with a fractured severe osteoporosis. Now remember that about 50% of the spine fractures occur in somebody has between -1 and -2.5 in the area of osteopenia, which is very curious. So we'll talk about that in a minute. Basically, the more it doubles basically with every standard deviation, the risk of getting a fracture. So you can kind of figure that once you go beyond -1.5 or 2.5, you're really going to double it and you can see this really when you look at this graph. Kind of Cirrus did this, and as you can see, as the score gets worse, the number of fractures simply goes up, which makes pretty common sense, obviously. So the trabecular bone score is an emerging tool. It's simply a program you put on your DEXA scan, and it'll really tell you and look inside the vertebrae around the osteophytes. It's derived from the DEXA, and it looks at the trabecular architecture. And it will tell you the deterioration of that microarchitecture. And as it does, you have increased bone fragility and may not even suffer a hip fracture, and the bone's more susceptible to fracture. So it's something to look at about adding this program to your DEXA scan. It can be very useful for us spine surgeons. And this is what it looks like. It gives you this beautiful nomogram that you see here that'll tell you where you fall between between L1 and L4. It'll tell you where they have normal values. And not only that, it will calculate, because it is a DEXA scan, all your BMD, your T scores, your Z scores, and everything else for every level from L1 to L5, and also combination levels. So it's definitely a tool that if you practice a lot of spine surgery, you ought to consider implementing. Now we'll talk about CT Hounsfield units here. It's an optimistic CT. We get them all the time. You can get it from a reformatted abdominal scan, all sorts of things, and it will identify low HUs, which can be pathognomonic for fracturing. And it may actually disagree sometimes with your DEXA scan. And as you can see, the older you get, the lower your Hounsfield units get. And when they get down to about 50, you're probably in a lot of trouble. And they start to drop pretty rapidly after the age of 50. Men start higher, but we do catch up with women around 80. Now, if anybody ever wondered what PACS is, Paul Anderson taught me this: picture archiving and communication system. And basically what we're going to do is make an elliptical measurement. You can either do it in the sagittal or axial view. You should use the axial. It's more accurate and more consistent with what most of the studies look at. And you can just go down the menu here and you can calculate the centroid really quickly. And you can see that the axial will inevitably be anywhere about 10 to 15% higher, as you see here, than what you have with the sagittal. So most of us will use axial views, usually L1, L2, L3. You can average them together, and they will be different when you measure them, but they'll give you a general idea. So when you measure these Hounslow units, this is a little bit what I use really just to explain further, but you can see 203, you're okay. You get down to about 160, you're going to start to see PGK at a higher instance. You get down to 112, you're going to have osteopenia and so forth. So once it's below 110, you probably definitely have osteoporosis. And if you go below 50 or lower, you probably shouldn't do surgery till you treat the patients. You're going to have a lot of problems. So when you look at Hounslow units predicting complications, you can see that if they're 112, you're going to have more complications than when they're 150. Only makes sense. Pretty common. Here's another study that was done by Jane that I really like that recently came out. And what he basically concluded is 50% of the no treatment osteoporotic patients had osteoporotic related complications a year after spinal fusion. And 61% had instrumentation and 32% sustained a new vertebral fracture. This is really incredibly high, which is why we're experiencing all the problems we have and everything. And not only that, since we're going to talk about costs and everything else, it costs an extra 20 grand to fix these people. So when you look at what Hounslow will predict, all these different studies, you can see that the threshold, when it gets down to 120 and below, you start getting proximal junctional kyphosis, fractures, sagittal imbalance, cave subsidence, etc. Now, these three other modalities you can use if you want, the BCT, the QCT, and the BBQ, but you can kind of research those on your own if you'd like. So when we plan, there's all these articles about the incidence of osteoporosis. If you look at this, you can basically see here that 45 to 60% of the people we operate on have poor health. So why are we doing this? Why aren't we paying attention to it? Well, I think more people are, and that's been very encouraging that there is an osteoporotic God out there. So also, when you look at vitamin D deficiency, there's a very high incidence of vitamin D deficiency in patients. You can see that almost 50% of the people in the Stoker study had vitamin D less than 20. That's really profoundly low. And other studies have shown similar results, and that will vary from study to study, but it's pretty consistent. When you look at vitamin D3 levels and how they affect things, the time to fusion is very dependent on the D3 levels. And if you supplement it, you can see the odds ratio of decreasing your risk of getting a non-union are much higher, is what Ravanda found. He also found that basically the lower the vitamin D3 levels, the lower and the slower the fusion rate. So when it's minus 20 and 20 and 30, you can see it takes many months longer to get a solid fusion. Now, Bajurki looked at this and basically found that if you have really low HUs and poor bone quality, you're going to have a lot of complications, pseudoarthrosis, kyphosis, and hardware failure. And you can see the osteoporotic related complications approaches 50%, as does the non-union, when basically you have poor bone and osteoporosis and everything. So it's really a major deal. This is a recent paper that actually my fellow showed me that he participated in, Justin Vickery, and they found that if your HUs are below 163, that's the threshold risk of preventing PJK. So there's an awful lot of people out there getting operated on with 110, 120, and I can tell you that they're very likely to get PJK with a long adult spinal deformity. So the results of optimization, treatment requirements. You always start people on calcium, vitamin D, exercise, water aerobics, but we have all these marvelous medicines that over the last decade or two that have come out, really culminating in the three anabolic medications that we can actually reverse the terrible effects of osteoporosis. So this really pretty much summarizes how they work for those of you that are curious and somewhat like biochemistry. Basically, the PTH stimulates osteoprogenitor cells to make bone. The teriparatide stimulate the same receptors and they do the same thing. And teriparatide actually is Forteo. And of course, we also have abaloparatide, which is the other commonly used one. We also have romosozumab, which is another product out there, and it blocks sclerostin, and it also turns on the osteoprogenitor cells. We also have basically the bisphosphonates that block reabsorption along the line of remodeling by the osteoclasts or like osteoclastic poisons. And finally, we have denosumab, which also will bind to the cells, preventing the formation of osteoclasts and slow down bone reabsorption. So one works by slowing bone reabsorption and one works by building bone. And we can play with these medications back and forth to actually sequentially build up bone strength. Denosumab is commonly used. The thing you have to remember, it blocks the RANKL and it prevents osteoclasts from really forming in a way. You look at them, patients have been on them for a while, and they'll have no osteoclasts visible anywhere in the field under microscopic examination. But they do lead over a long period of time to more bone. The other ones, Ramosumab is another very powerful one that's available, and that's been extensively studied here and also in Japan, along with Ramosumab. But the bottom line is that Ramosumab, if you take it for a long period of time, you must stay on it because there will be a rebound effect if you stop it. But it absolutely positively will prevent fractures and complications, as you can see here when you compare no Ramosumab with Ramosumab. Another one, of course, what we really like to talk about is weekly teriparatides. There's absolutely no question that these will build 25% bone health within 3 to 4 months if you're prepping a patient for surgery. And just all the Japanese studies that we go through quickly, they basically say that weekly teriparatide will make more bone on an osteoporotic patient. And if you want to review anybody's series, review Otero's, who looked and found that it improves fusion rates, that it improves fixation, the screws don't come loose, and it works better than the bisphosphonates, which have been in the traditional treatment up to this point. Teriparatides undoubtedly are a positive effect on bone healing. It doesn't really improve fracture healing, but with fusions, for whatever reason, because it's woven bone, they do appear to dramatically improve the rate of fusions. So that's all led to our CNS guidelines that I help write along with the team of superb neurosurgeons, in this case, including SIG's partner, Praveen, and I was very grateful to be part of this. And the guidelines are very clear. If you should always do DEXA scanning, CT, and vitamin D throughout levels. And if you find the minus 2.5 and Hounsfield units at D3 level, you absolutely should counsel the patients about it and treat this. So there's a strong recommendation to do all this testing and discussion with the patient. We also found that preoperative teriparatide, because Ramosumab had not quite come out yet, is recommended for osteoporotic patients. And it's a grade B suggestion, which is pretty good when you go through a process like this and have experts talk about it. We did not find that basically the bisphosphonates, there was insufficient evidence for them, although it probably does. It's almost simultaneous to this. Zishan Sando, who's part of our osteoporosis group with the Spine Health Foundation, he found that anabolic agents are very, very strong and work best. And he also said the same thing, that we should always check these patients before we operate on them. Finally, the last recommendation, of course, is by Paul Anderson, who just recently published this, and it's kind of a compilation about what we've talked about the classification, about when to do your testing as far as DEXA testing, and basically the different categories of osteoporosis culminating in severe osteoporosis when you have a fracture combined with a minus 3.0 score. You really need to treat those patients. They should not be operated on unless it's an emergency situation, or you're going to end up spending a lot more money on them. And so it basically leads to an algorithm that if you have a high risk patient, you want to refer them or treat them. I suggest you get a fracture liaison service, which will be talked about to do this. And if you're low risk, you can treat them yourself with vitamin D or calcium and send them and get them on a bisphosphonate or something and proceed with surgery. So, kind of in summary, the most efficacious way to identify osteoporosis and optimize surgical outcomes is to establish a fracture liaison service, a really kind of slick name that people have come up with, and most notably Paul Anderson, with guidelines for treatment. If you do this, you can dramatically cut down on the number of postoperative complications that we've kind of breezed through here and improve the patient's chance of having a successful outcome. You really are treating two diseases. You're treating the bone health problem, the bone itself, and the stenosis and the deformity, but you also have to treat the underlying bone. If you don't do that, you're going to have an awful lot of complications and failure to fuse and PGA-K that we've all been seeing. So hopefully, as we institute fracture liaison services across the spectrum of all people that do spine surgery, this will lower the rate of that. So thank you very much for listening.
Dr. Bervin is a member of the spine service at UC San Francisco, holds a joint appointment in orthopedic and neurosurgery, and he leads the UCSF Spine Surgical Home Program. Dr. Bervin studied human biology and economics at Stanford, studied philosophy, politics, and economics as a graduate student at Oxford, and then completed medicine at Harvard Medical School, followed by residency at the Harvard Combined Orthopedic Program. Currently, Dr. Bervin's clinical interests include complex spinal deformity in the adult and pediatric patient. His research interests include studies on the value of interventions, including non-operative management, operative strategies, and new technologies. He serves on the board of directors of the Scoliosis Research Society, the Evaluation Committee of the American Academy of Orthopedic Surgery, and a number of other organizations there. And I've been cut off from reading your bio there, Dr. Bervin, and it will be available on the website for everyone to read through. So we'll turn it over to you now.
Good. Thank you, Rita, for the introduction, and John, terrific background on why this is such an important topic for us now, and the importance of bone health optimization. So I'm going to build on what John's talked about and talk about some of the healthcare economics that go into episodes of care, and specifically accountability across an episode of care, why the preoperative phase of care is important to us. These are my disclosures, I think none of which are going to be relevant for the talk today. Uh, as an overview, I think that reimbursement reform can be a really powerful driver of healthcare change. And right now, in a fee-for-service healthcare economy, there's a lot of limitations that lead to a unsustainable rate of rise of healthcare costs. So I think risk-sharing strategies are part of the era that we're entering, and this is what Teams and the CMS effort is about. We'll talk a bit about risk stratification in spinal reconstructive surgery specifically, and recognize, as John indicated, that osteoporosis is a risk factor for failure, period. And I'll share with you a systematic review that we did on that. John did a nice job of talking about measuring bone health and the techniques for doing that, as well as some of the limitations and the recognition that depending on the technique, we might get different values. And understanding all of these may well support the role for bone health optimization before surgery. And then finally, working on effective perioperative protocols. So understanding the difference between urgent surgery and elective spine surgery, I think that we can really do quite a lot in terms of optimizing people before surgery and trying to minimize perioperative complications. Ultimately, the point of risk stratification has to do with empowering people and surgeons to make informed choices, to understand expected outcomes, and this is where we can really make a difference. I'm going to start with this as a background. Back in 2000, I believe, this was our decade of bone health, and that led to the opening of our burden of musculoskeletal disease program and our musculoskeletal disease, the burden of musculoskeletal health program. And that was a decade of bone health, and that continues to be a priority in our healthcare system. And one of the reasons I say it's a priority is that spinal disorders overall are an important priority. If we define priorities for healthcare as disorders that are prevalent and also disorders that are impactful, the disorders that we as a community of physicians who take care of patients with spine problems treat are important. And recognizing the priority of spinal disorders in our healthcare economy, I think we've got to also recognize some of the deficiencies of our healthcare system. And right now, there are real deficiencies in the US with regard to access to care, disparities in access, a lot of variability in how care is provided. In some cases, some really inappropriate use of care. There's no other country in the world that's got problems with personal bankruptcy that the US has. And we've got a healthcare system that's unsustainable with regard to the rate of rise in costs. We're nearly $5 trillion a year now in our healthcare budget, and we're not getting outcomes that really justify that level of expenditure. And there's a lot of nonsense in reimbursement. Right now, I think our fee-for-service healthcare economy is based upon volume rather than value. There's a clear disassociation between reimbursement and the outcomes of care. And the moral hazard involved here, I think, is important to understand, is that there's a risk segregation or a disassociation where patients are taking risk and the surgeons and healthcare systems are getting reimbursed. And I think trying to align that is an important priority. And this disassociation of risk and outcome, this disassociation of reimbursement and volume really has an impact on a rapid rise and an unsustainable rate of rise for healthcare costs for our economy. And that's where I think reimbursement reform can have some real value. Again, I think our current fee-for-service healthcare system has led directly to an unsustainable increase in cost without a clear improvement of outcome or of value in care. And I think Dr. Cunningham is going to build on this further. And reimbursement reform, I think, to some extent, may be seen as some tsunami on the horizon, or some kind of a weather event that we don't want to sail into, or it may be a utopia. And I think we're the ones who are going to determine what the future for reimbursement reform is going to be. I think the work of Porter and Kaplan is important to recognize. And in addition to textbooks, they wrote this article in Harvard Business Review about how to pay for healthcare. And a big part of our strategy exiting the fee-for-service world is risk-sharing programs and accountable care organizations. I think about Kaiser as being an example of that, are certainly one option where we have a global capitated budget, the Canadian healthcare system, where you pay for care over the lifetime of the patient. Another is to bundle payments for the episode of care. And as you recognize now, for many DRG codes for spine surgery, as well as joint replacement, as well as fractures, we're entering now in a mandatory way the bundle payments model. We had quite a bit of experience with this at UCSF as a model where we weren't actually accountable for the results. We found out that our expenditures were not competitive with bundle payments, but now this is something we've really got to take into account for and make some real and measurable changes. When we think about the episode of care, so much of our effort in terms of our day-to-day work, as well as perhaps our perspective, is focused on the acute care in the hospital. So the admission of patients to the hospital, operative care, and perioperative care in the hospital. What we learned about with bundle payments is how much of cost is actually in the outpatient setting. And in some cases, up to 50% of care might be in the postoperative setting. And also, we recognize the importance of what happens preoperatively. So the importance of what happens in the outpatient pharmacy, what happens with the clinics, and recognizing that that can have a big impact on the cost of acute and postoperative care. So again, reimbursement models that we've done work with, fee-for-service, the merit-based incentive programs, BPCI, accountable cares, narrow networks, employer-sponsored healthcare. All of these, I think, are important models that have an influence on physician behavior. And right now, again, we're going to focus on a bundle payment system and transform the TEAMS model, basically transforming episode accountability model. With regard to spine fusions, this encompasses a variety of primarily lumbar fusion procedures, both front and back and posterior fusions. And if you look here, just what the episode costs are for a 30-day bundle, you can see what the averages are, and depending on anchors, there's different variations. But when we looked at this within UCSF, our mean and standard deviations were far from these averages, in general, deviating above the averages. And to that end, that's something that's got to change. Otherwise, our healthcare system will be bankrupt, or at least our hospital system will be. I want to review with you some a paper we wrote. I think this was an important paper that was published last year, looking at mechanical complications in spine surgery, and specifically osteoporosis as a risk factor for mechanical complications. And what we looked at, this is some of the background, we looked at 30 and 90-day reoperation rates for patients with spine surgery. And we identified some specific variables that included, as you'd imagine, longer fusions, patients who had a longer length of stay, which is a proxy for comorbidities. But osteoporosis was one of the significant risk factors, even in a multivariate analysis, for readmissions. And this is an area where this is going to be costly if we don't reduce that or identify that prior to surgery. This is a predictive tool that we use to identify specific factors, and we use a machine learning model, and we showed that osteoporosis, again, was an independent predictor, one of many that went into a risk tool for 30-day readmission. There's a lot of literature about osteoporosis and mechanical complications, and what I'll share with you is, and John's gone through some of the methods for measuring bone density. What I want to emphasize here, as John mentioned, is the DEXA score isn't standing alone, and that the trabecular bone score can significantly alter those numbers and the risk of fracture. It's important to understand this trabecular bone score, as well as other tools, including the FRAX score, which John mentioned, where a threshold that if you've got a risk of a major osteoporotic fracture or a hip fracture, then a risk of a major osteoporotic fracture more than 20% or a hip fracture more than 3%, then those are also thresholds, even with a T-score that's more than minus 2.5, that may justify anabolic therapies. So we looked at 71 studies that looked at spine complications and osteoporosis. Most of these had DEXA scores. Some of them used alternative methods, as you've heard about a micro CT, quantifiable CT, Hounsfield units. And these were the outcomes we looked at: cage subsidence, screw loosening, non-union, junctional complications, reoperation, new fractures. And the two that were perhaps most sensitive to bone density, all of these were risk factors. All these complications were at risk for osteoporosis. The two that were most sensitive were cage subsidence and screw loosening. So these are outcomes that we can really look at and that are highly associated with osteoporosis, and that may be a valuable outcome when we look at therapies and interventions in the future. So what we want to do is limit perioperative risk across the continuum of care. That's fundamental to our risk sharing systems. And focusing on preoperative concerns, we want to look at medical optimization, and bone health optimization is a really important part of that. John's already shared with you the work of Zisan Shardar and Larry Lenke. This was a multi-center effort looking at guidelines for the assessment and appropriate management of bone health in patients undergoing elective surgery, and identifying who should have bone health optimization. And in general, anybody over age 65 and people under age 65 in a lot of different classifications. And then some recommendations with regard to the appropriate treatment. There may be no area of medicine that's more variable than appropriate treatments. Nancy Lane is part of our group here at UCSF, who's done some very important work with bone health, and others from UCSF are part of this group. This is my preoperative risk stratification form. So every patient who I indicate for surgery, I look at bone sugar or blood sugar, bone health, BMI, nutritional risks, infection risks, smoking, and I try and optimize these factors prior to elective spine surgery. That transforms. And how do we actually get this done? Well, we created a preoperative order set where patients who don't have adequate social resources at home see a social worker before they're in the hospital so we can prepare things. Patients who are smoking, we've got a smoking cessation center. We've got a skeletal health center. We've got patients who are taking more than 50 milligrams of morphine, see our pain management doctors, all this before they come to surgery, because each of these factors are associated with perioperative complications that can be avoided. This is our skeletal health service. I think Einar Sawyer has joined us tonight, but it's interdisciplinary. It includes orthopedics, endocrinology, and a number of radiologists as well. And optimizing bone health and getting patients to an optimizing program is a real priority for a lot of patients, especially our spine and fracture population. So I'm going to end there by concluding that spinal disorders encompass a broad spectrum of pathologies and require care from multiple disciplines. Those disciplines are also involved in bone health care. We recognize that readmission, reoperations are significant and modifiable costs in spine surgery, that healthcare reform is an important and powerful driver of change. Shared risk models, I think, can really incentivize a lot of changes, and I think that the CMS team program clearly provides a strong incentive for preoperative optimization before patients have spine surgery or joint replacement surgery. Again, preoperative optimization can have an important and measurable impact on cost, on readmissions and revision surgeries. And the goal of system reform is really to develop an evidence-based approach to identify risk factors for complications and to create a consensus in how we treat patients appropriately. So thanks for the opportunity to contribute. I'll end with the words of Francis Well Peabody from Boston, who really said one of the essential qualities of a clinician is the interest in humanity, because the secret of caring for the patient is to actually care for the patient. And I think there's no area where we can be more caring than to prepare patients appropriately before we subject them to reconstructive surgery. Thank you.
We're going to keep the program moving along. I'm going to introduce Dr. Brian Cunningham, our last speaker for tonight. Dr. Cunningham is the Vice Chair and Director of Inpatient Orthopedics at Methodist Hospital Health Partners in St. Louis Park, Minnesota. He is also the Director of Ambulatory Surgery for TRIA. Dr. Cunningham is certified with the American Board of Orthopedic Surgery and a member of the Orthopedic Trauma Association. In October of 22, Dr. Cunningham was appointed the chair of the OTA Practice Management Committee, serving a 3-year term there. Most recently, he was elected CFO for the OTA. He sits on the Healthcare Systems Committee for the AAOS and was a member of the Patient Reported Outcomes Work Group for the AAOS. In 2016, Dr. Cunningham founded the Value Initiative with a mission to quantify and implement value-based healthcare through research, innovation, policy, and technology. Dr. Cunningham has built this research area with over 100 peer-reviewed publications, as well as numerous book chapters. And I'll turn it over now to you, Dr. Cunningham.
So here's a few things, this is kind of the overview for the talk, why bone health matters in teams, the surgeon's role, which I think is overlooked and often miscategorized, and then, how do you implement this in real life? So why it matters. It's been mentioned a little bit, but perioperative complications will loom large in the teams model, specifically ones that affect the 30-day spend. Failure reoperation lumbar fusion is another one. Inpatient falls at our hospital, most people that have a fall that's reported, the injury is a fracture. So the more you can do to prepare your patients for surgery in this model, the better. There's been a bunch of really good literature thrown out there. I'm just going to put a couple up here briefly. But as was mentioned before, Paul Anderson, if you evaluate patients for primary total joint arthroplasty, you will find a number of those patients that need treatment for osteoporosis. Similarly, most recently talked about anabolic interventions, a cost even or a break-even analysis. I think this is a great paper. And I'll just say at our shop, we typically will use Timulose for most of our anabolic procedures or anabolic medications. This is a big slide because this really looks at how do you manage your osteoporosis. Total hip, total knee, lumbar fusion, MSK care upstream from the anchor procedure. Hip fractures, trauma, that's all downstream. So you've got to try to sort through how do you capture these patients? How do you optimize them? Is it preoperative? Is it postoperative? We in trauma, we don't get a lot of say on who comes through the door, but we do get a lot of say on what happens afterwards. And I think there's a learned helplessness that we're fighting through on the trauma side of things. And we got to catch up to our elective colleagues. So a surgeon's role, I would be remiss if I didn't credit a couple of people. Mark Swinkowski independently got Methodist to the #1 site on Own the Bone at AOA by doing this in his own clinic. Most of us don't have that, commitment and/or intellectual horsepower. But I do think all of us can take a look at this and say, man, this is a big mess. Like teams, one of the challenges with teams, and I'm sure Adam touched on this or Christian last time, but teams does not create alignment with the private practice physician. And so if you're in private practice and you're going to do extra work or pay extra attention to what's going on, you have got to get one of your partners that understands business to broker some type of an agreement up front that creates alignment. Because when you have alignment, you have influence and you have capacity to make real change. If you're completely unaligned, it's going to be a rough go. I'm an employee of a big health system. SIG works for a big health system. Louisville's a big health system. That all makes sense. But if you're in a private practice, I think you got to figure out how to create some alignment with your system. So surgeon's role, we have one of our scrub techs who's a legend, always says surgeon's the captain of the ship. And I think there are a few occasions when that's still true. You can manage your schedule. You can decide when you put people on the schedule and what hoops they have to jump through, how much optimization they have to have. You're really the catalyst for protocol development. I saw Sig put that nice kind of roadmap for his patients preoperatively up there. I like that a lot. I think as total joint arthroplasty continues to progress into a press fit world for everyone, everywhere, all the time, osteoporosis diagnosis and management will continue to be super important. And then you can also motivate your patient and educate them in a way that nobody else in the system can do. Your voice to a patient still really matters quite a bit. And I think if you take that on and provide them with insight, that can be really meaningful. So let's talk a little bit about our situation. We had kind of Mark Swinkowski doing it on his own, which is obviously not scalable or sustainable. And so we looked at, how do we optimize bone health and our system for taking care of patients with osteoporosis. And so first we kind of identified the need, and it's a little bit embarrassing, but like there was no access. That's a fundamental problem. There was no process, and there was no follow-up. I mean, it's hard to get worse than that, to be honest. It feels like we weren't doing anything, but I'm confident there's a lot of places that are in that same situation right now. And so step one, we hired a full-time provider that doesn't operate, and all they do is bone health. And then we incentivize their production so that the more work that they did, the more or the better their compensation was. We provided multiple clinics so that patients didn't have to seek this person out, and referring providers didn't have to seek this person out. And then we leveraged video visits and phone visits for a lot of these interactions. Step two is we really worked on system-wide referrals, educating the internal referral. That's as much of a challenge as anything. The trauma surgeons take care of the patient, and they don't make a referral, or the spine provider books sees a consult, and then they're getting ready to book him out 3 months for surgery, and nobody makes a referral. So you really got to win over your own people first. And then we took steps with technology and Epic to automate the consult so that it was hard for them not to make it. We have an NPPA floor team that kind of substitutes for our residents and fellows at our hospital and across our system. And we really leverage that group. So they do an osteoporosis consult inpatient on every fracture patient that comes in that's over, I don't know what the cutoff is, but I think it might be 65. And we have a mobile outreach service that will do visits in a skilled nursing facility or a TCU. And so we educate that group as well. And then lastly, when the patient comes back, it's typically the kind of 6-week visit in the trauma setting. We really do a lot of patient education. We look in their chart, we say, have you seen bone health yet? Make sure that's on the schedule. We track follow-up for bone health. We're working to continue to study and optimize our results and publish those. And then I think this is one of those really important facts that gets overlooked a lot. The revenue from this system feeds back into the system. It doesn't go into some magical budget some administrator takes away and gives you a new target the next year. We really try to incentivize financially this system to continue to provide resources for itself, and that when they're winning, they get to keep the earnings and leverage that for programs and whatever they need to use. So in brief, I would say leverage teams to drive bone health at your organization. It is not directly one-to-one related to teams and the financial incentive, but Medicare wants every single patient by 2030 to be on a risk-bearing contract. So you got to figure out how to take risk and how to manage it well. I can tell you right now, there are going to be a handful of shops that opt in big on teams and make a lot of money. And one of the things that you can get out of that is you can get a really robust bone health program to piggyback on top of that. I would say surgeons are critical to implement bone health programs. I think a lot of times we're viewed as, we view ourselves as extramural or on the outside looking in, and that's just not the case. We have to be the driver. And then no matter what you can do, if you can automate a process, it trumps effort and incentive every single time. So the more you can leverage technology in EMR to help that, I think the better. And with that, thank you.
Thank you, Dr. Cunningham, for that incredible perspective from the orthopedic fracture standpoint. A really comprehensive look here on these episodes in team, everything from the spinal fusion to the femur fracture, hip fracture, and the arthroplasty. So really appreciate these great presentations from our speakers. We're going to move now to our Q&A session. And I think what I'll do here is I can just go ahead and read these questions out. I think everybody can see the questions, but we'll start with a question at the top here from Dr. Sethi for Dr. Bervin, and it reads, thank you for your presentation and enlightened worldview on spine healthcare economics. In traditional FFS fee-for-service models of healthcare, how can payers choose systems that remain FFS but want to move towards a risk stratification protocol that chooses value?
Yeah, Raj, terrific question. And I've got to give the background that, Raj has done his master's in health administration and is really an expert in these systems. I think the answer there, which you know better than I, but a big part of this has got to do with, first of all, narrow networks. And if you've got a fee-for-service healthcare payer or system, then incentivizing payers to identify your system or to recognize the center of excellence, the center of value, the center of cost effectiveness. And truly, I think most people online know that Raj really did a lot of work towards that up at Virginia Mason in Seattle. I think the other area is also recognizing that up to 80% of our insured population under age 65 get their health insurance from employers. So I think looking at employer-sponsored healthcare programs as well, where it could still be a fee-for-service reimbursement, but at the same time, I think that would create some real incentives from the payer to identify value-based programs.
Thank you for that. I'll move to the next question. Again, this is from Dr. Sethi, a question for John Dymar. Dr. Dymar, you've been a champion for bone health and spine deformity patients for a long time. Appreciate your dedication to this. What can an orthopedic or neurosurgery service do to justify bringing on an internal endocrinologist or an advanced practice provider to own the bone health equation for the patients?
Great question. Thanks, Raj. I think we have been successful. We use nurse practitioners, and we started with one, and now we're up to two, and they're both very busy with this. And you can build the program in such a way that it will virtually, at the very least, break even, and often, in a lot of ways, be profitable. And I think when you do enough patients and do enough time, I know that I've been told that there actually is a Medicare boost, which may be involved in this team's affair, I'm not sure, that actually will make the reimbursement even better as far as Medicare patients. And so we've actually, by the time you add the facility fee and the nurse charge for seeing the patient and a testing panel that we order, it really works out that you can actually break even at the very least. And so I think that's the first thing that the hospitals worry about is having a loss leader. But there's been building so much pressure, as you pointed out now, to treat this, particularly in spine with a lot of the non-unions and failure to fuse. And also, we have to remember over the last decade, we actually have metabolic bones that can, medications rather, that can build the bone metabolically and actually improve the strength of the bone rather dramatically because we understand bone physiology better. And so I think it's something that you initially may lose some money on, but once you get your nurse practitioner full, which doesn't take very long, people will start sending you patients that are actually non-spine patients and non-operative patients, but you'll get orthopedic services to send broken hips and stuff. You can make it as busy as you open up the window to get into it. And so we've been very restrictive. We really just do spine optimization as our first key. And then if there's extra slots available, then we'll fill it in with orthopedic referrals or general referrals from the community.
Thank you,
Does that
Dr.
help?
Dymar. Yes, thank you. And Dr. Cunningham, did you want to comment?
Just briefly, I think it's really important that you have your administrators understand the value and the
Yes.
economics of infusion and the infusion center that your patients are going to be referred into, because that is the ASC of medical pharmacy.
And you shouldn't inject denosumab in your office for $60. You should send them to an infusion center where you get more. You shouldn't try to basically administer romosozumab in your office. You could send them to where you get the infusion charge from Medicare, which is acceptable, and that will in fact cost more, but you'll help support the program so you can treat more patients. So it's a very cyclical thing. And so just knowing how to manage the insurances is really important. And we've had a remarkable shift in approval of these drugs to the point that we almost never get them denied anymore if you can justify it, but you just have to know how to justify it.
Thank you for that. I'm going to move to the next question from Walter Aronson. This is a question for Dr. Bervin. Do you think that because reimbursement models usually fail to account for social determinants of health, among other variables, they are partially responsible for the health disparity gap that affects underserved populations? And do you believe that part of the solution would be to add health equity metrics into reimbursement models?
Walter, thanks for that question. I think we recognize now more than ever how important social determinants of health are in determining health quality of life. And to that end, we're actually, our NASS meeting, many of you will be there next week. Two of our papers are on healthcare inequities and the social determinants of inequities. With regard to how do reimbursement models fit into perpetuating inequities, I think that this has got to start in the primary care area. This has got to start with access to care. This has got to start not necessarily in reimbursement for spine surgery, as much as getting everybody universally access to a primary care doctor, getting everybody universally access to appropriate screening. And I think that we as a spine community are certainly an important part of the healthcare economy, but I think reimbursement's got to start with getting adequate access to a primary care doctor and screening programs. So long before somebody comes to spine surgery. But reimbursement is a big part of the incentive. And right now, primary care doctors aren't getting reimbursed enough. And in fact, in a fee-for-service economy, if you don't do a service, if you don't perform a procedure, you're generally being underpaid.
Thank you.
Yeah, I just want to answer one question there, Rita, from
Yes, John.
Deborah,
Mhm.
about how long you treat with Timlos. Timlos, which is alabaloparatide, you treat 18 months. Some people treat 24, but it's really 18 by the brochure. Evenity, which is romosozumab, that's 12 months. But that may change because they're doing 2-year studies now too. It doesn't seem to be much effective beyond 12 months. So you're going to have to cycle people perhaps to a bisphosphonate. So just to keep in mind, just to answer that question.
Thank you for that answer. We're just coming up at 9 o'clock, but we've got one more comment in here, one more question from Ann Lake, and this is a question for Dr. Cunningham. Dr. Cunningham, can you repeat the statement that by 2030 Medicare will require?
Yeah, we had a call with CMMI. I'm on the health systems practice committee that Kevin Bozick started with AAOS a number of years ago. We had a call with CMMI. They want every single CMS patient in a risk-bearing contract by 2030.
Oh.
It's a wild goal, but you can tell where the direction of the organization is headed. And I don't think that has changed with the administration. So you will see more pressure to perform than ever before.
We are going to bring our program to conclusion on the remaining 2 sessions in this team series. Our next session will be on Wednesday, December 3rd. The topic is leveraging the advanced practice providers to optimize CMS team patient outcomes and reimbursement. We touched a little bit on that tonight. We're going to take a deep dive into that in our next session. And then our last session is that date. We're still working on that date with Dr. Shankar and Dr. Curry from Mass General, and they will be talking about a team implementation guidance. They're going to talk about what they are doing in Boston at their hospital, and so that will be from a C-suite perspective as well as the healthcare professional within a system. So these are the last 2 sessions that are coming up. We do have a landing page on our website where you can watch the playbacks of these videos and get the schedule for the next videos. We will certainly be pushing that information out for registration, so you can take a look for that information as well. And then just in closing, it looks like Alex has shared the link. If you want to register now for session 3, that registration link is available in the chat. And again, just want to thank our sponsors, Medimaps and Radius. Thankful to their educational grant support for making these programs possible. It's a big round of thanks to our sponsors. And again, thank you to our speakers. Again, this program will be available for viewing in about a week on our website. And with that, we conclude the program, and I wish everybody a good night.